sub-tailor in there too, but everything we did distal to that, using the, making the diamond, closing the diamond, and doing the joint play, you don't need to do on this exam. Okay?
No joint play?
What's that?
No joint play for like...
Well, I don't know about the written.
Okay, well...
But for this, there's no joint play beyond ankle mortise. Alright? So...
ankle, you gap the ankle mortise and that's it.
Pretty much. It's fine if you want to add in the sub-tailor gapping, when you throw that in. Dr. Hammer and I talked about, we were perfectly acceptable of just the first part of that, but I have to remember to mention that to Dr. Feinstein.
Cool.
Okay? So you can say, Dr. Dillard said that we only have to worry about the ankle mortise or talotibial. You guys remember how to do that? So there's a couple of ways that we showed you. One was they're on their back. You get your hands. Now we did show you with your fingers interlaced, and once I tried to do that on somebody, it actually hurts my fingers to do it that way. So what I typically do is put my hands over. What the key is you want this barrier right here, and you want that to be on the talus. So you don't want that up on the tibia. You want that on the talus, and you're going to gap that down. You don't want them to be in plantar flexion. You want them to be in ankle neutral, almost going into a dorsiflexion as you do that. And then you're going to take up the slack and go 1/8 of an inch more. Joint play, 1/8 of an inch. You go to the barrier, 1/8 of an inch beyond it. Okay? Not more than 1/8 of an inch. The other way was on their back, and then you can sit between them and the table on your back and cut up there. So if I'm treating her left side, in the way that you're evaluating this is you can get your thumb right on the talus, which is just inferior to the tibia, and you can dorsiflex them. And you want to evaluate how they do that. This one is restricted too. So bend this knee, and then I tell them I'm going to sit between your leg and the table. And I come in here. I put my back side against her thigh, because I don't want, remember, she doesn't want you to do this. You're not moving with her. I'm resisting motion there. I really have to dorsiflex her to get at the right angle of ankle neutral here, and then I'm gassing. So I take her to the barrier and go 1/8 of an inch beyond. Alright? The other part we did with that is we also had her knee bent up, her ankle bent up, we stabilized the talus, and we moved the tibia on top of that. So if you're not getting a release, then you can do this part. Are we going to require you to do this? I don't know. But those are the two parts of that. Okay? This one?
No, for the gapping. For the first gapping.
Oh, when I was like this? Okay. So I put my fingers, I want to be on the talus. I don't want to be up on the tibia, and I don't want to be down here on the bottom, on the top of their foot. So, and I'm going to put her into ankle neutral, and then I'm going to take her to her barrier, and I'm going to pull. You're going to want them to hold onto the table so that you don't pull their... You don't want to internally rotate, because you don't want to grab onto their innominate and give them an innominate shear. Remember, that's how we treated superior innominate shear. So you don't want to give them an inferior innominate shear. You want to keep their toe pointing up. That way, you might gap their hip and their knee, but you're not going to gap their... you're not going to pull down their innominate.
Is that how your hands were when you were in between her thighs too?
When I was in between her thigh, my hands were like this. So how they're positioned is that you're basically just below the medial malleolus and the lateral malleolus at the same time. You want to be on the calcaneus in the back, and you want to be on the talus in the front. And that's the highest bone on the ankle. Okay? You want to get them into a little bit more dorsiflexion, and then take them to the barrier.
Can you gap when you sit? Like, would you visit, or either or you have to hold?
Yes, no, either or. It was, if you do it this way, remember you're crossing a couple of joints, which are one of the rules she didn't like you to break, but she said this was the exception. So if you do it sitting, also if you're doing, again, you don't have to do it for the exam, but if you're doing sub-talar joint, if they have an issue with inversion, eversion, it's a whole lot easier to just position them in that, do your distraction, then drop and do your up and down. So I tend to do the other one, but occasionally I do it this way.
For the sub-talar, like without even showing it, let's say for distraction, you kind of yank forward a little bit, right?
Yep.
And then you
you throw down and you throw up.
and you help the same way, right?
Yeah, except you're a little lower because you're on the navicular.
Okay, yeah.
Yeah, and so as you're throwing, you're holding the navicular, trying to get the talus to move off the navicular. So you're a little lower on the.
Right? Like as you go down.
Yes. Yep. The navicular is that bump in the medial part. Okay. So fibular head. Fibular head, right? So fibular head, as you can compare them both at the same time if you like. Remember, in what angle does the fibula move?
30.
Okay, but it moves at a certain sort of. Does it move when it moves posterior? Does it move lateral or medial?
Medial.
It moves medial. When it moves anterior, it moves lateral. So it does this when you're looking at the patient from the end of the table. They move away from you, come towards you, widen out. All right. So if you get on their fibula and you just go, if this is her tibia and this is her fibula, and you just move straight forward and back, we might not like that so much. Okay. You want to get at this sort of angle for her right one. Okay? So if I come on here, I can compare both of hers to see how they move. And in general, I feel that her, oh, you are all messed up. Her right one doesn't move forward easily, but it moves back easily, but then I can't get it to move forward well. And her left is the opposite. Her right is a bigger issue. So her right fibular head is stuck posterior. It's a posterior fibular head. It likes to be posterior. We want to pull it forward. So what do we have to do to pull it forward? How are we going to position her foot? We want to plantar flexor because we want her to use the front of her leg muscle to pull that forward. So by plantar flexing her, she's going to, when she pulls her toes up, when she dorsiflexes her ankle, it's going to encourage that to move forward. I'm going to put my finger behind that fibula head to also encourage it to move forward. Now, we said that it's stuck back. So when it's back, it's this way. We want to internally rotate or externally rotate her to encourage it to move forward. Internally rotate her. Do you guys see that? So we want to internally rotate her to kind of bring this around so it will come forward easier. So you get on her, you put her foot down towards the table. Put this down. I like to leave their heel on the table because I find it really hard to hold them up and do this. So I take the weight off of me, and you can also do this with their leg hanging off the side of the table. You don't have to do it with them laying down. And I'm going to internally rotate her, and then I'm going to add a little inversion. It's going to just help. But really the plantar flexion and the internal rotation are your main points. Pull your toe up or your foot up towards the ceiling. So as she pulls her foot, I'm going to encourage this to move forward. As she relaxes, I'm maintaining my help moving that forward. Make sense? Pull up again. She pulls up. I encourage it to move forward. When she relaxes, I maintain that, pulling that forward and internally rotating her a little bit more. Make sense? All right. So if she's anterior and we want to push her posterior, we want to have the back of her muscle or the back of her calf tight. So we're going to dorsiflex her and encourage her to plantar flex. Also, we're going to externally rotate her to encourage that to move backward. All right. And go ahead and push her toe down. So she pushes her toe down. I encourage it from the front by pushing it back. Relax. As she relaxes, I maintain my pressure to encourage it to go back, etc. And then you reevaluate. Okay. And hopefully you go, wow, that was so much better. Okay? All right. So, hip and shoulder, right?
Tibia.
Oh, tibia. Sorry. Thank you.